Dear class, this is the second part of sex and adrenal hormone. So this part will talk about sex hormones. Sex hormones produced by the gonads are necessary for conception, embryonic maturation, and development of primary and secondary sexual characteristics at puberty. The activity in target cells is modulated by receptors. The gonadal hormones are used therapeutically in replacement therapy, for contraception, and in management of menopausal symptoms. Several antagonists are effective in cancer chemotherapy. Estradiol, also known as 17-beta-estradiol, is the most potent estrogen produced and secreted by the ovary. It is the principal estrogen in the premenopausal woman. Estrone is a metabolite of estradiol that has approximately one-third the estrogenic potency of estradiol. Estrone is the primary circulating estrogen after menopause. Estriol, another metabolite of estradiol, is significantly less potent than estradiol. It is present in significant amounts during pregnancy because it is the principal estrogen produced by the placenta. Non-steroidal compounds that bind to estrogen receptors and exert either estrogenic or anti-estrogenic effects on target tissues are called selective estrogen receptor modulators. These include tamoxifen and raloxifene, among others. After dissociation from their binding sites on sex hormone binding globulin or albumin in the plasma, steroid hormones diffuse across the cell membrane and bind with high affinity to specific nuclear receptor proteins. The activated steroid receptor complex interacts with nuclear chromatin to initiate hormone-specific RNA synthesis. This results in synthesis of specific proteins that mediate a number of physiologic functions. Estrogen are most frequently used for contraception and postmenopausal hormone therapy. Due to concern over the risk of hormone therapy, the National American Menopausal Society recommends that hormone therapy be prescribed at the lowest effective dose for the shortest possible time to relieve menopausal symptoms. The primary indication for estrogen therapy in postmenopausal women is menopausal symptoms such as vasomotor instability, for example, hot flashes or hot flushes, and vaginal atrophy. For women who have an intact uterus, a progestogen is always included with the estrogen therapy because the combination reduces the risk of endometrial carcinoma associated with unopposed estrogen. Synthetic estrogen analogs are these compounds such as ethinyl estradiol and mestranol. The synthetic estrogen analog have a prolonged action and a higher potency compared to those of natural estrogens. Estrogen are transported in the blood bound to a serum albumin or sex hormone binding globulin. To reduce first-pass metabolism, the drugs may be administered via the transdermal route, patch, topical gel, topical emulsion, or spray, intravaginally, tablet, cream, or ring, or by injection. Nausea and breast tenderness are among the most common adverse effects of estrogen therapy. Postmenopausal uterine bleeding can occur. In addition, the risk of thromboembolic events, myocardial infarction, and breast and endometrial cancer is increased with use of estrogen therapy. Selective estrogen receptor modulator or SOMs are a class of estrogen-related compounds that interact at estrogen receptor but have different effects depending on tissue. That is, they display selective agonism or antagonism according to the tissue type. This category includes tamoxifen, raloxifene, and clomiphene. Tamoxifen is currently used in the palliative treatment of metastatic breast cancer in postmenopausal women. It may also be used as adjuvant therapy following mastectomy or radiation in breast cancer and as a prophylactic therapy to reduce the risk of breast cancer in high-risk patients. Raloxifene is approved for prophylaxis of breast cancer in high-risk women and also for prevention and treatment of osteoporosis in postmenopausal women. Clomiphene has been used successfully to treat infertility associated with anovulatory cycles. Progesterone. The natural progestogen is produced in response to luteinizing hormone by both females, secreted by corpus luteum, primarily during the second half of the menstrual cycle and by the placenta, and by males, secreted by the testes. It is also synthesized by the adrenal cortex in both sexes. In females, progesterone promotes the development of a secretory endometrium that can accommodate implantation of newly forming embryo. The high levels of progesterone that are released during the second half of menstrual cycle, the luteal phase, inhibit the production of gonadotropin and therefore prevent further ovulation. The major clinical uses of progestogens are to treat a hormonal deficiency and for contraception. For contraception, they are generally used with estrogens, either in combination or in sequential manner. Most synthetic progestins used in oral contraceptive, for example, norethindrone, norethindrone acetate, norgestrel, levonorgestrel, are derived from 19-nortestosterone and possess some androgenic activity because of their structural similarity to testosterone. Progestins are also used for the control of dysfunctional uterine bleeding, treatment of dysmenorrhea, and management of endometriosis and infertility. Mifepristone, also designated as RU486, is a progesterone antagonist with partial agonist activity. Administration of this drug to females early in pregnancy usually results in abortion of the fetus due to interference with the progesterone needed to maintain pregnancy. Mifepristone is often combined with the prostaglandin analog misoprostol to induce uterine contraction. The major adverse effects are significant uterine bleeding and the possibility of an incomplete abortion. Drugs are available that decrease fertility by a number of different mechanisms, such as preventing ovulation, impairing gametogenesis or gamete maturation, and interfering with gestation. Currently, interference with ovulation is the most common pharmacologic intervention for preventing pregnancy. Combination oral contraceptives. Products containing a combination of an estrogen and a progestin are the most common type of oral contraceptives. Monophasic combination pills contain a constant dose of estrogen and progestin given over 21 days. Triphasic oral contraceptive products attempt to mimic the natural female cycle and most contain a constant dose of estrogen with increasing doses of progestin given over 3 successive 7-day periods. With either type of combination oral contraceptive, active pills are taken for 21 days followed by 7 days of placebo. Withdrawal bleeding occurs during the hormone-free interval. They are available in transdermal patch, vaginal ring, progestin implants, progestin intrauterine device.